guys, welcome back to my channel. For those of you who are new, my name is Brianna, aka Dollface PA. For those of you who are returning, thank you for coming back. Quick disclaimer, so after I recorded this video and I looked, the whole video, it looks like I don't have on a shirt, but I do. It's just a tube top, and the way the camera stops, it only shows from like here up. So I wanted to show you guys myself to show you that I am wearing a shirt. If you are new, don't forget to like, comment, and subscribe and turn on post notifications. I'm going to jump right into today's topic. Basically, it's just going to be a day in the life of a hospitalist PA, which is what I am. My subscribers have asked me to walk through what a typical day at work looks like, and so I'm going to do just that. So let's get into it. So I'm a hospitalist PA, which is internal medicine. In internal medicine, there's inpatient and then there's outpatient. People who go see their internist usually are seeing an internal medicine provider that practices in the outpatient setting. I work in the inpatient setting. So internal medicine inpatient provider is often also known as a hospitalist provider. So you will hear me use the terms interchangeably. Basically, I have very long days. My shift is a 12.5-hour shift. So my morning starts pretty early. When I first get to work, the very first thing that we do is receive sign out from the night team. And so the patients that I will be receiving for the next day were being managed by another team overnight, because obviously somebody has to be at the hospital at all times with the patients. And so I receive sign out, like a verbal sign out from the providers from the overnight team. They will tell me about any issues overnight, anything acute that happened, anything that I need to know about the patients. Oftentimes, I don't know these patients at all. If I'm coming in on a Monday and I've been off for the weekend, this may be a brand new list. Typically, it's anywhere from 11 to 13 patients. 13 is usually our cap. And 13 is when we're like really, really surging. May not sound like a lot of patients, but I promise you it is. After I receive sign out, we pre-round, which is basically when we just sign into the computer and we scroll through the charts of all of the patients that we have and basically just read up on the patients, review why the patients are admitted, what is their past medical history. You read the H&P to find out what was the reason for admission, why are they still here in the hospital, what tests are pending. Like, you pretty much just scroll every patient and learn everything you need to know about the patient. You're reviewing vitals. You're reviewing anything that happened overnight, if anything at all happened. What medications are they on? What is the primary diagnosis? Why are they here? And usually I will print out a list of all my patients and I will just write all of this information down on the paper so I can take it into the room with me when I go see my patients on rounds. It's very useful because it's not really possible to keep all of those details straight without having something with you. And we do have our phones that we take in the room, but I don't really particularly like scrolling on my phone to like read through a patient's chart when I'm patient facing. It feels kind of rude and disruptive, like when you're having a face-to-face conversation with the patient, but like you're also scrolling on a cell phone. So I try to keep all of my notes written down on a paper. So after we finish pre-rounding, reviewing all the labs, reviewing everything, we do round with the attending physician. And so usually the attendings come in a little bit later once they've reviewed the patients as well, or sometimes they already know the patients. We will go see all of our patients. Rounds are rounds. We go see the patients, we do a physical exam, we talk to the patients, we find out, you know, is anything new? Has anything changed? We go over the plan for the day with the patient. This is what's going to happen today. And if XYZ happens and everything's okay, you may be discharged home, or you may be discharged back to your nursing home, or whatever the case is. We just kind of go over that plan with the patient. Depending on how many patients we have, rounds can take very long. Sometimes maybe even about 2 hours, because you are like doing a very comprehensive interview and exam with the patients, especially if you're meeting them for the first time. And so it's thundering outside. And so, yeah. And also sometimes there's a language barrier. I do not speak Spanish. We serve a very, very large Spanish speaking population. And so oftentimes we're having to call an interpreter on the phone. That takes time because sometimes there's like a barrier with the language. So All of these things factor into why rounds take so long. Once we are finished seeing all of our patients, we have interdisciplinary rounds, which is when the medical team, so it would be myself usually, because the attending physicians usually don't go to interdisciplinary rounds. It would be myself, the nursing team, social work, care coordination. All of us have a meeting to discuss why each patient is still in the hospital, what needs do they have for when they leave the hospital, what tests are pending, et cetera, just so everybody on the treatment team is on the same page as to what is going on with this patient and what will be needed in order for us to have a safe discharge plan for the patient. So after rounds with the patients, I go to interdisciplinary rounds with the rest of the treatment team. So usually all of this together takes probably about, I would say, 3 hours. By the time I get settled back in the office after doing these two things, it's usually afternoon. So the first thing I do when I get back to the office is to place all of my consults. So the way that I know what consults need to be called is because we just saw the patients. If, our patient is endorsing a new symptom to us, or if on chart review we notice that maybe the labs are a little off, the creatinine is rising, okay, maybe we should consult nephrology. I'm the one that places all the consults. So I go through each of my patients, determine who needs to be consulted. I place the consults, the consultants call back, I present the patients to the consultants, and we kind of go from there in terms of developing a plan. So I like to call my consults as soon as I get back in the office, because sometimes it can take the consultants a little while to call back. So you kind of want to get on that as soon as possible. Also, in addition to calling my consults, I place any orders that need to be placed. Sometimes, let's say for instance, on rounds, the patient is complaining of abdominal pain and they're saying they haven't had a bowel movement in several days. It's okay, maybe we should get an x-ray of the abdomen just to make sure that there's no obstruction or anything like that. So when I go back to the office, I will put in that order for abdominal x-ray or any imaging studies, any lab studies, anything that needs to be placed as an order. I do that when I go back to the office. It is possible for me to place these orders while I'm on round seeing the patients, but again, I find that it's more distracting to continually be pulling my phone out to place orders. I would rather just write down on my paper what orders need to be placed and place them when I can sit down in my office and think about the orders that I'm putting in. And I find that works very well for me. In addition to placing orders and consults, we call family members to update family members about the status of their loved ones. This is definitely a very integral part of my day. It's something that I do every day, but it's not happening as much now that the visitation policy is a lot more laxed because COVID is on a downstroke. But before, when they weren't allowing visitors in the hospital, families literally would not know what's going on with their loved one unless we call them. So I would spend hours and hours of my day calling every family member of every single one of my patients to give them the whole rundown of what is going on, why they're still here, etc. And so a lot of the times now, the family members just come to the hospital to see their loved ones, and we usually will just go to the bedside and speak to the family members to update them about what's going on. That's probably bulk of my day. Also on rounds, as I stated earlier, we are going through the plan for the day. And so there are a good amount of patients that get discharged every day. They're discharging home, they're discharging to a subacute rehab, they're discharging to a nursing home, independent living facility, wherever they're going. They have to be discharged from the hospital because once they're medically stable to leave, we need those beds for other patients that are boarding down in the ED. And so we do discharge summaries. Basically, it's a comprehensive document of everything that's taken place from the time the patient walked through the emergency room to the time they left. We make their appointments, their follow-up appointments. Let's say a patient needs a follow-up neurology appointment and a primary care appointment. We make those appointments. We put all of those appointments in the discharge summary. And because the discharge summary is a comprehensive document, it kind of takes a while to go through the whole thing. So that takes up a lot of my time as well during the day, especially if I have multiple discharges. And if a patient has been in the hospital for an extended period of time, the discharge summary will be very long. If they've had like an ICU course and then were transferred out to the floor. So I spend a lot of my time doing discharge summaries, making sure that all of the loose ends are tied up. They have all the appointments they need, everything. They have everything in place that they need not to be lost to follow up, because that's a huge problem in healthcare. And so, I work on my discharge summaries. I discharge my patients. We're in communication with the social work team for patients that may need transportation home, or, transportation may be arranged to get a patient back to a nursing home if the patient is non-ambulatory, or anything of that nature. In terms of the team dynamic, we are working very closely with the doctor. In the morning, we do round with the doctor. But the doctor usually leaves pretty early in the afternoon. And so after the doctor leaves, we are the sole providers there that are responsible for the patient. So we're assigned into every patient as first call, meaning if anything happens, the nurses are calling us. The doctor's gone for the day. So there's a pretty good chunk of the afternoon until the end of my shift where you are managing all the patients by yourself. Anything that's coming up, any problems, family questions, anything you're dealing with. So I wanted to highlight that because there is a very huge sense of autonomy. Like, you definitely are still, it's not like, oh, I'm just working under the doctor, I don't get to do anything by myself. That's not at all the case. Like, it's more of a collaborative relationship that we have with the MDs. Sometimes, like, if you don't know what to do, if your patient is crashing, the doctor is always available to help you, which is very nice. But they also empower you to feel like you can make clinical decisions, and you should be able to trust your own clinical judgment when something is happening, and you can make the right decision for what needs to happen for the patient. So that's also really, really nice. That's pretty much my day. It may not sound like a lot, but it is. And I mean, even in the midst of all of this, there's rapid responses happening. Sometimes there's codes happening, which we do go to those. Like, we are just as much as part of the rapid response team and the code team as anybody else is. Even if it's not my patient, if I show up to a code, I'm going to do chest compressions. That's just how we are, because we all help each other out. And so, when you throw those little things in here and there in the middle of a day where you already have so much to do, the day can be very hectic. Not to mention if you have really sick patients on your list, which we do manage step-down level patients. So it's very possible that of my 13 patients, 4 of them might be step-down level. For those of you who don't know, step-down is just one level down from ICU. So they're not requiring intensive care unit level of care, but they're just one step below that. So they can be very sick. Like, you're constantly in the room, you're constantly making sure that the patient is stable. So after all of these things are done, I make sure all my patients are tucked away. The last thing that I do for the day is sign out. And so the same way I receive sign out from the night team, I sign out to the night team before I leave. Anything that needs to be followed up, whether it's consultant notes. Sometimes the consultants won't put their notes in until later. Or if there was like a lab that I ordered that still isn't back yet, I may ask the night team to follow it up. If there's anything that needs to happen overnight, that's a to-do, I would verbally sign that out as well as on a paper to the night team. And then I go home for the night. And then I come back in the morning and I get sign out from those same people on the same patients, and it's kind of the same thing. And so the way my schedule is, though, is pretty sporadic. So I'm not always coming back to the same patients. But if I'm working several days in a row, they typically would try to keep me with the same patients just for continuity of care. But one of the nice things about my job is that when I sign out to the night team and I clock out, my work for the day is done. I do not do notes at home. I don't work on anything at home. And that's really good for me mentally because it allows me to really disconnect from work. When I come home, I am off the clock. I'm not working. I am not finishing up things that didn't get done at work. I mean, sometimes there are things that need to be finished. And if that's the case, I will just stay at work late to finish it. I don't bring it home with me. And so I hope that answered the question for, the subscribers of mine that were asking to hear more about my day-to-day. That's it. That's what it is. I love it. Great, great, great job. And that's it. If you guys have questions, feel free to hit me up in the comments. Don't forget to like, comment, and subscribe. I will see you guys on the next video. I'm actually going to be bringing a couple of my coworkers on for my next video, and I'll see you guys then. Thanks for watching. Bye. Love you.